My name is Dr. Noga Schiller, and I am the Veterinarian Medical Advisor at BioGal Lab. And in this video, I want to discuss the clinical applications of PCRun. So I'll be going over various infectious diseases and talking about how and when we use PCR to diagnose these diseases. But before we start with that, I want to briefly go over what even is a PCR test. So a PCR test is a highly used method that amplifies a specific segment of DNA many times. So it can make millions, even billions of copies of a specific segment of DNA. And this can be used to detect many types of microorganisms, and it is extremely useful in diagnosing infectious diseases. Now, in this video, I will be comparing it mainly with serological antibody tests that detect antibodies for specific infections. And these tests can lead to false positives and false negatives, while PCR will detect the presence or the absence of the pathogen itself. So with the standard PCR, we're going to have 20 to 40 cycles of changing temperature. So we'll have heating and cooling in each cycle. And this requires complex equipment and trained personnel. So these kind of PCRs we're going to have in laboratories where we'll send out the material, and the test itself takes several hours to complete, but as clinicians, we'll usually get results in a few days. So for PCRun, on the other hand, PCRun is an isothermal amplification method that uses a single temperature to amplify DNA. So we don't have this heating and cooling system, and in that way the equipment can be much more affordable and compact and portable, and it can be performed by any veterinarian or veterinary technician, and we have a much faster turnaround time because it is in-house. So the test itself takes no more than 75 minutes to complete, and we have our results. The PCRun kits that are available, you can see here a table of all the PCRun kits available. So we have many infectious diseases that we can use PCRun for. And as you can see, they all have a high sensitivity and specificity. And so now I want to go over all of these different diseases. And in particular, I want to talk about the pathogenesis of these diseases. Now, why do I want to talk about the pathogenesis? Because we need to remember that PCR is finding our pathogen. So in order to know where a pathogen is in the body, it's really important to understand the pathogenesis of each disease. So let's start with Ehrlichia Canis, which is our most frequent form of tick-borne diseases in dogs. So Ehrlichia canis will infect the host via tick bite during a blood meal, and it'll multiply in macrophages in the blood. From there, it spreads to lymph nodes, to the spleen, and to the liver, and this is our acute phase of the disease. From here, it can pass to our subclinical phase, where the microorganism will remain sequestered in the spleen. So it's going to hide out in the spleen, and it's not in the blood anymore. From the subclinical phase, we can have spontaneous resolution of the disease or a passage into the chronic phase of the disease. And in the chronic phase, we have infiltration of E. canis in lymph nodes, in parenchymal organs, and in bone marrow. So what does that mean for the diagnosis? So there's two main diagnostic methods. We have our serology IgG method, which is a blood test that will look for IgG antibodies, and we have our PCR. So during the acute phase, when we're using serology, we can have false negatives in early stage because the first stage of the disease, we don't have antibodies yet. It takes some time until the antibodies are produced, in particular IgGs. We can maybe get a diagnosis by repeating the test after 4 weeks to check if we have a 4-fold titer increase. So if we do, that's more indicative that the infection is current, but that does require waiting 4 weeks. And a big problem with checking our IgGs, checking our antibodies, is that the dog might not be currently infected because it can be positive also if a past infection occurred. It is more useful during our subclinical and chronic phases, And we might have a strong positive, so it's important to have a quantification method where we know that we have a lot of antibodies. We have a high level of antibodies that is more indicative of a current subclinical or chronic infection. PCR, on the other hand, so for our acute phase, it's a really good method to use because, like we saw, our pathogen is present in the blood. So if we're checking our PCR in the blood, it is highly sensitive and specific. For subclinical and chronic phase, it's a little bit trickier because, like we saw, the pathogen will hide out in the spleen or in the bone marrow. So it probably will be negative in blood, but it can be positive in spleen or bone marrow aspirates. And when it comes to our non-infected dogs, the PCR will be negative because the pathogen is not present. Now let's move on to Anaplasma Platys. So Anaplasma Platys infects the host via tick bite and will multiply in the platelets for 1 to 2 days. From there, it leaves the peripheral blood for 1 to 2 weeks, and then it will go back inside the peripheral blood for 1 to 2 days. So it has this cyclic pathogenesis, and this causes cyclic thrombocytopenia and fever every 1 to 2 weeks. And this is also really important to understand when we're diagnosing, because we have our serology IgG that's very similar to Ehrlichia, that we can have false negatives in early stage, and it can be positive if a past infection occurred. And we also have problems of cross-reactivity. With PCR, it is highly sensitive and specific, but it can be negative in the blood because of this cyclic nature. So we can also perform bone marrow and splenic aspirates. And if the dog is not infected, our PCR again will be negative. Babesiosis. So when we're talking about babesiosis, it infects the host via tick bite, also blood transfusion and intrauterine, and it'll multiply in the erythrocytes. From there, it can cause a systemic inflammatory response that can lead to a multi-organ dysfunction. When it comes to babesiosis, it's really important to understand the classification because there are 2 forms that can cause infection in dogs. We have our small form and our large form. Our small form, the most frequent one, is Babesia gibsoni, which is less pathogenic usually, and the treatment is different from our large forms. And that is really important to understand for diagnosing because, as you can see, if we have different treatments, we need to understand what species it has infected our dog. So our large form is Ehrlichia Canis, Vogeli, and Rossi, which in general is more pathogenic and it has a different treatment from the small form. It's treated with imidaclopropionate as opposed to the small form, which will use atovaquone or azithromycin, and it usually won't allow a definitive clearance, and it's much more frequent that relapse will occur in the small form. So when we're diagnosing babesiosis, with our serology IgG, there is a cross-reactivity between species, so we can't differentiate the different species. We again have false negatives in early stage, and again it can be positive if past infection has occurred. PCR, on the other hand, is highly sensitive and specific in blood, and it can differentiate the various species, so we know which Babesia we have and how we treat it. And if the dog is not infected, again, the PCR will be negative. Hepatozoonosis. So hepatozoonosis infects the host via ingestion of infected arthropod. So it's not during a blood meal, but it's ingestion of this arthropod. Usually it's ticks. In cats, it might also be fleas. We're not sure yet. And it penetrates the intestinal wall, and it enters the mononuclear cells. From there, it disseminates via the blood or the lymphatic stream, and it enters and reproduces primarily in bone marrow, in lymph nodes, and in spleen. But it can be in other organs like the liver, the kidney, the pancreas, and the lungs. So it can kind of be all over the place. We need to remember that. And from there, it re-enters the bloodstream. So when it comes to diagnosing our serology IgG, just like the previous ones, we can have false negative in early stage, and it can be positive if there was a past infection. PCR is a really good method for diagnosing hepatozoonosis. It's highly sensitive and specific in the blood, and if the dog's not infected, again, it is negative. So let's talk now about a disease that's a bit different than our tick-borne diseases that we've talked about up until now. We have our Leishmania Infantum. Leishmania, the infection is most commonly caused by the sandfly during a blood meal, and it will multiply in macrophages, and it can infect visceral organs, primarily lymph nodes, spleen, and bone marrow. And it can cause, again, like babesiosis that we talked about, it can also cause an inflammatory response in different tissues, mainly the skin and the eyes. Those are the most common ones. Now, this is a really complex disease that I'm not going to get into too much detail over, but there are different stages and levels of this disease, and it depends on the immune response of the animal. But in general, some don't, they develop a chronic form, and we will have a low antibody count in this form. This is very in general. When it comes to diagnosis of this disease, we have cytology. Now, I didn't talk about cytology up until now in the tick-borne diseases. It is possible to do cytology. It is pretty rare to identify those microorganisms in cytology. So if you did identify them, great, you have diagnosed the disease, but again, it's rare, so it's not really a super useful diagnostic tool. For Leishmania, it might be a little bit more useful. We can use scrapings, discharge, or FNA from lymph nodes, from spleen, bone marrow, skin, and the sensitivity is a bit better. If we take from bone marrow, it's been reported between about 52 to 85%. Lymph nodes is still pretty low, between 50 and 60%. So it's not super useful, but if we do identify in the blood smear, that's great. And then we have our serology IgG. It is a sensitive method. It's really good in dogs with clinical signs. Sensitivity with the IFA is up to 90%, but without clinical signs, it's only at 31%, and there can be problems with cross-reactivity. PCR, the most sensitive is to use lymph node or bone marrow aspirates, while blood and urine is less sensitive, and it's particularly useful when our serology is inconclusive or the dog is not seroconverted. Mycoplasma Haemofelis infects the host via tick bites, and we have a pre-parasitemic phase that can last 1 to 3 weeks. From there, we pass to an acute phase where the microorganism attaches to the erythrocyte membrane. From there, it's sequestered in the spleen, in the blood, and the bone marrow, and then it can return to the bloodstream. So it's also cyclic, like anaplasma, and these cycles can last hours or days. And then if we have a sufficient immune response, we will pass into the recovery phase of this disease, where there's few organisms in the blood, but these cats can become carriers for months or even for life. So this is also important to understand when we're diagnosing this disease. So for diagnosis, we have cytology, but it's only seen in about 50% of the times during the acute phase, so not super useful. Then we have our Coombs test. Our Coombs test is often positive for Mycoplasma, but it's not specific for Mycoplasma. And a negative test does not rule out infection. The PCR, on the other hand, is highly sensitive and specific in blood, and we can differentiate the various species. And it's also useful for screening carriers. So when we want blood donors or when we want SPF colonies, we can use PCR to differentiate between those that are shedders and those that are not shedders. Now I want to talk about two viruses, Parvovirus and Distemper Virus, that, as you know, these are core vaccine viruses. So we always have to remember that when we're diagnosing these diseases, that the patient might have been recently vaccinated. So for Parvovirus, the infection is by oral nasal exposure of contaminated feces. It will replicate in lymphoid tissue of the oropharynx, the thymus, and the mesenteric lymph nodes. From there, there's a dissemination into the bone marrow and the intestinal epithelium, and intestinal damage will allow the passage of Parvovirus into the bloodstream. So the diagnosis of Parvovirus, we have our serology, but in this case, the serology IgM. So we're looking for IgM antibodies. These are antibodies that are the first to be produced during an acute disease. So they indicate early infection. So when we have an infected dog, we'll have elevated levels of IgM. A recently vaccinated dog, though, can also be positive. So we'll have our false positives when there's recent vaccination. And then we have our fecal antigen test. The fecal antigen test has high specificity but low sensitivity. There can be false negatives in a few cases, in early stages of the disease, or if it's been more than 10 days since the infection, or when we have the presence of maternally derived antibodies. Those can interfere with this test because they will bond with the antigens, or when we have low shedding. And in cases of recently vaccinated, we might have false positives, maybe after a vaccination with modified live vaccines, but this is not conclusive. PCR is highly specific. It has good to very good sensitivity in feces, in blood, and in tissue, in particular the pharynx. When it comes to recently vaccinated, we can have false positives up to 28 days post-vaccination, but these will in general be weak positives. For distemper virus, the infection is by oronasal contact with aerosolized secretions, and it infects the monocytes in the lymphoid tissue of the upper respiratory tract and the tonsils. From there, it proliferates in lymphoid organs, and then it will spread to epithelial cells of respiratory, gastrointestinal, urogenital tracts, and the central nervous system, so a bunch of different places. And from there, we can have shedding of the virus. When it comes to the diagnosis, so also here we have our serology with IgM, that elevated levels will indicate an early infection. And vaccination, we can have false positive up to 3 weeks post-vaccination. Our PCR test for distemper virus, we can use blood, conjunctival, nasal, tonsillar, or rectal swabs, and it has a good sensitivity and specificity. Urine is a good choice if we have encephalitis caused by distemper virus. And when it comes to vaccinated puppies, so we can have false positives 1 to 2 weeks post-vaccination, but we can use a cutoff value of 107,903 to differentiate between a vaccination and a wild infection. For feline leukemia virus, or FELV, so it infects the host mainly via contact with infectious saliva, but there are other ways. It invades the local lymphoid tissue, and from there it invades monocytes and lymphocytes, and it'll spread to peripheral tissue, including the bone marrow. And after bone marrow infection, we can also have a secondary viremia. So for FELV, it's important to understand that we can have 4 different outcomes of the disease. We can have a progressive infection. In this case, the cat has poor specific immunity and a low antibody count, and these will be shedders. There will be viral shedding in this form. And then we can have regressive infection, where the immune response contains the replication of the virus, but it doesn't eliminate it. And in this case, we'll have high antibody count and no viral shedding. So that's a really important difference between the two. And then we have our abortive infection with a strong specific immunity response, high antibody count, and no viral shedding. And then we have our focal infection that is rare. So when it comes to diagnosis of FELV, we have 2 main tests. We have the antigen test. The antigen test is positive for regressive and progressive form, but it can't differentiate the two. In order to differentiate the two, we need to repeat the test at least twice. And most cats will be positive only after 30 days. We can also have false positive when we have different hematological disorders like IMHA, and we can have false negatives in early infection. PCR, on the other hand, also detects progressive and regressive forms, but it can differentiate the two. So if we have less than 1 million copies per ml, it's the regressive form, and if we have more than 1 million copies per ml, we have the progressive form. And most cats are positive after 1 week of infection, so it's much It's a much earlier detection. We can have false negatives if the virus is not at that moment present in the bloodstream. Let's talk about our final disease for this video, which is leptospirosis. So leptospirosis, we also have to remember that it is a core vaccine in many places in the world. So when we're diagnosing, we have to take into consideration if this animal was recently vaccinated or not. So leptospirosis infects mainly through contact with infected urine. It'll attach to the endothelial cells and break them down, and from there it passes to the bloodstream, and it spreads and replicates in many organs, including the kidneys, liver, lungs, spleen, eyes, genital tract, and central nervous system, so almost everywhere basically. So the diagnosis of leptospirosis, we have serology with IgM or with IgGs. This test will have cross-reactivity. A titer of 1 to 800 or more in non-vaccinated animals and 1 to 1,600 and more in vaccinated can be suggestive of infection, but it's not diagnostic. And it is recommended to repeat this test twice in a 7 to 14 day interval. There can be false negatives in early stage. When it comes to PCR, it's recommended to use a mix of blood and urine because we'll have a lepto more in the early stage in the blood and in the late stage more present in urine. We can have false negatives if we've already started antibiotic treatment. However, in general, if we have positive blood PCR and clinical signs, this is diagnostic for leptospirosis. So thank you very much for joining me in this video. I hope it cleared some things up. And if you want more information about PCRun and about the different kits that we have available, just click on the link below and enjoy.